Hi friends. At DAMS we have initiated a Medicine Unplugged series of videos which I'm sure many of you are following us on YouTube and DAMS Daily page on Facebook, where we try to present to you in a clinical and a integrated fashion a disease where so that you can understand and apply it on a multiple choice question. And I want you to know today is that today the pattern of multiple choice questions worldwide, when we talk about our NEET exam or AIMS exam or even USMLE, has gone towards integration. So just knowing about one aspect of a disease is not going to help you. You have to look at a disease from its pathogenesis point of view, from the clinical presentation, and to see how we diagnose it. So today we have chosen a unique pulmonary disease in which I will be showing you the radiological part and Diksha will be with me and talking about the pathological part. Like you have seen in the past, we have done a lot of radiopath series on YouTube. You can actually look back and scroll back and see more of our videos on this approach. Now today we have chosen a case of a 35-year-old female patient. She came to us for a CT scan of the chest because of the history of respiratory insufficiency. She has no history of smoking, no history of tuberculosis, she is not HIV positive, and no history of any collagen vascular disorders. So this was the history that we have had with us, and I'll tell you the reasons why we took those negative histories. I'm sure most of you clinicians would have already picked up that why we are asking negative history in the beginning. I'll tell you because the CT finding was very specific. So let me load the CT scan from my workstation here. I'll show you how to actually look at a CT chest. This is the DICOM images of the CT chest, and we are looking at the lung window, and we'll go step by step. Okay, I am going from top to bottom. You can see this is the section at the level of the apex. You can see the trachea and you can see both the lung apexes, and I'm going down. In between you start to see, I'm sure you are able to see some small thin walled cyst in both the lungs. Okay, they're scattered in both the lungs. It is not like it is more in the apex, they're scattered in both the lungs, multiple thin walled cysts in both the lungs. I'll show you more once I go down, and they're more in the lower lobe. If you see, they're more in the lower lobe. Okay, they're more in the lower lobe. Okay, so more in the lower lobe. Now if you can see here in this section again, you can see multiple thin walled cysts scattered in both the lungs, more in the lower lobe, and a young female patient is the history. Okay, so now if you look at this section in front of you now, this is lung window of the CT chest, and look at the lower zones. This is probably the area of the CP angle where you can see some cysts. Can you see multiple cysts in both the lungs, more in the lower lobes? There's no evidence of any interstitial lung disease, no fibrosis, no bronchiectasis. We don't see any other thing here. Only cyst, thin walled cyst scattered in the lung, young female patient. So in such a appearance, the first differential diagnosis that you should consider is a disease called as Lymphangiomyomatosis. This is a female predominant disease, especially seen in premenopausal females with thin walled cyst in both the lungs. Then why did we take the history of smoking here? Why did we ask for history of smoking here? Because we wanted to rule out one of the most important differential diagnosis in a patient with multiple cysts in both the lungs is Langerhans cell histiocytosis. Pulmonary LCH or pulmonary variety of this disease is usually associated with smoking. A smoker in the history, I would have thought of LCH as a DD, but this patient we asked, are you a smoker? She said, no, I'm not a smoker. So now we know a female patient, premenopausal age group, non-smoker. Another of the DD that I will keep here radiologically is a disease called as lymphocytic interstitial pneumonia. But usually that is seen in HIV patients or in patients with autoimmune diseases. That is why, if you see in the history, we have ruled out if there is any patient is HIV positive or not. We had tried to rule out the association of any collagen disorders. So usually LIP is associated with HIV, Sjogren syndrome, or autoimmune thyroid disease, SLE. These are the associations that we look at. And in addition to the cyst, these patients will also have some ground glass haze in the lung, would have some mediastinal lymphadenopathy, which is not seen in this patient. So on the basis of what we have seen so far, the main differential diagnosis that I would keep here is LAM, lymphangiomyomatosis, is the feeling that we get on the CT scan. Now I'll invite.
So LAM is a very interesting entity to look at. It actually falls under the category of a group of tumors called picomas. perivascular epithelioid cell tumors. So in front of you, what you see is a histopath photograph, and let's trace our way through it. I hope all of you can appreciate some empty spaces in between that are traversing, anastomosing here and there. All of those are the lymphangio channels. So that is the lymphangio part of the lymphangiomyomatosis. And in between those channels, you can see these short bundles. And if we were to zoom in on them, we'd see that they were spindle shaped like the myoid cells, like muscle cells. That's why we call this lymphangiomyomatosis. And this tumor is said to have both a myoid origin and a melanocytic origin. So to establish that, of course, we resort to immunohistochemistry. And on immunohistochemistry, this is a slide showing immunohistochemistry for smooth muscle actin, which tells me that this has come from a myoid origin. So if I were to do a stain for HMB45, that would also be positive, telling me that this has come from a melanocytic origin. So that's why we would finally consider the diagnosis.
And I like to actually add here is that on the histopath, you actually saw beautifully dilated lymphatic channels seen as empty spaces. And that is one of the reasons why these people this young woman can actually come to you with a recurrent chylothorax.
Right.
That is one of the presentations that happens sometimes. Or a recurrent pneumothorax is also a possibility. So beware of a young woman with honeycomb like multiple cysts in the lung on a chest x-ray, with with a recurrent chylothorax, then lymphangiomyomatosis would be a possibility. And I would also like to add here is that we were talking about LCH, Langerhans cell histiocytosis of the lung. Usually that would be more in the upper lobe, and the cyst will be more bizarre in shape. Now, if you notice here, we actually saw this disease more in lower lobe. That is why we did not keep LCH as the differential at the first place.
So picomas, like I said, they are perivascular epithelioid cell tumors with both myoid and melanocytic origin. And one very interesting thing about them is that since we've seen that these are seen in premenopausal women almost exclusively, they also express progesterone receptor. And that has a bearing on treatment possibilities as well.
Yeah, I'm sure oophorectomy is also one of the treatment modalities. This is the logic behind it. So that is where learning the epidemiology of a disease helps you. That you saw that this disease is common more in women, and especially in premenopausal women. So in a scientist in you, you should always remember a doctor is also a science student. Should always think, why in a young woman? Why? There has to be something. And that is where the discoveries happen, and you realize when you go on the molecular level or the pathological level, you saw that the progesterone receptor is positive in these people.
And these patients are also seen to be associated with TSC2 gene, that is tuberous sclerosis. So that's another association syndrome that we can see. So which brings me to the next group of tumors, the entire group of tumors of picomas. So picomas ke under the tumors that we have are angiomyolipoma. Again, if you notice, look at the word angio is giving you the vessel part, and the myo is giving you the other muscle part. So that can be both renal and extrarenal. Then there's a tumor called clear cell sugar tumor, and its name is very interesting. Apparently when it was initially discovered, they saw that there were some past positive substances within the cells, and they were found to be hexose in origin. So hexose, the term came to sugar, and that can be seen in both lung and extrapulmonary. And the one we discussed today, lymphangiomyomatosis, all three are associated with tuberous sclerosis. There's one more type of picoma called clear cell myomelanocytic tumor of falciform ligament, which has not shown an association with tuberous sclerosis.
So actually, looking at the way, my pathology colleague has actually highlighted one of the points, I can actually see, because of my association with multiple choice questions for so many years, this is one of the potential MCQ that you can see in front of you. Which of the following picoma is not associated with tuberous sclerosis complex? The answer is clear cell myomelanocytic tumor of the falciform ligament. So this is actually a new thing that has come up, picomas, because when we were reading pathology at my time, this was not there.
It's not there in Robbins also.
It is still not there in Robbins, is what she says. So I'm sure you have to keep on a lookout for such topics for future MCQs. That is one of the messages that I want you to have through this media. And I also want you to learn a very important thing, that if you look at the diseases, look at the names of the diseases. Look at, say, lymph, angio, and angio, and say myo, and myo is also in the angiomyolipoma. So can you, and suddenly you can pick up that there is something similar in between these two disorders, and they are now, now the pathologists also see this, so they have classified them all together into a category called as picoma. And I would like to remind you to follow us on Dam City channel on YouTube and Dam City page on Facebook for more such videos. Our goal is to show you an integrated picture, like how a patient comes to us and how a radiologist looks at it. And if we do a lung biopsy, if we were not able to diagnose on radiology, we would have gone for a lung biopsy. And then how a pathologist looks at a slide and how we make a diagnosis and what is the pathogenesis of the disease. I hope you enjoy this video. If you do write to us in the comment section on this video. Do write to us on the inbox if you want to. We are committed to helping you integrate medical knowledge.